All right, so we're going to kick off with a question for Pedram. Has allogenic blood ever been tried for treating postural puncture headache?
I am not sure. Allogenic blood for PDPH?
Oh, has anyone used allogenic blood? So blood from a bag of red cells you've used, injected and squirted down the epidural needle for treating someone with a postural puncture headache after a wet tap?
I can't imagine why you would do that. If it were me, I think I'd rather have fibrin glue.
Mm-hmm.
Absolutely.
Okay.
Concur.
All right. This is for the whole panel. Let's say you've done a wet tap for someone who was your first pass, who's in labor, who's requesting an epidural. So the epidural needle is still in the back. What do you prefer to do? Do you normally prefer to thread an intrathecal catheter, or do you take it out and redo the block?
Oh, that's a great question. That's something I talk to the residents a lot about, because obviously it's something that's going to happen to everybody at some point when they do an epidural. So it totally depends on the patient, right? If it's somebody who I just wet tapped because they threw themselves back on me, if they can control themselves and I'm confident that I can easily and quickly do another epidural, then I'll go up another level. If it's somebody who I've struggled for the past hour to get an epidural and they weigh 400 pounds and their back is fused, well, then I'm going to thread the catheter and I'm going to take what I get. So it really depends on the patient, and patients in between will have in-between likelihoods.
Okay. Anyone else? Pedram?
I think depends where you practice. We use intrathecal catheters at UCSF. I would probably, since I don't cause the wet tap and the resident does, I just tell them to thread the catheter and we'll just use it.
Well, the only downside is, and I was really shocked when data on this started to come out, I thought, well, once I had an intrathecal catheter, then I'm totally cool if we have to go to C-section, right? Because at least I know where it is for sure. But it turns out that that's not the case, and they're as likely to fail as epidurals. So I'd really rather have a good epidural than an intrathecal catheter. And I always worry about the risk of someone giving the wrong thing through that catheter, and there are lots of case reports of that.
Well, my thought on that is, if you look at some of the data and the failure rates, some of them, they don't give a strong enough chance for the intrathecal catheter to work. They limit to 2.5 milligrams of bupivacaine an hour, and if it's not enough, some of them they call it a failure. I think there's some room to.
I think we all probably have the same practices, that we probably lean towards intrathecal catheters. I think the practice at Northwestern had changed from, in surveys over a decade, from about 25% intrathecal catheter to at least 75%. But I certainly also noticed how poor we were at managing analgesia with the intrathecal catheter. It's just, I think people are a little more anxious about it and tended to underdose them.
Actually, well, I disagree with you. I'm much more likely to try to replace it. The only time I don't try to replace it is if it's been really difficult to place.
All right. Actually, imagine a different scenario. Say you've got someone who needs an urgent C-section. Say she's 300 pounds, she's come in ruptured, she's had a prior C-section. You're thinking about, you wanted to do a CSE, and you place the epidural needle, and now you see CSF. What do you do in that scenario?
Then absolutely I'll thread the catheter because there's urgency. Yep.
Everyone else agree?
I agree.
Okay.
No argument.
Okay, Pedram, can you tell us about what doses you would consider, if you were going to consider, using COS, sinatriptan, or ACTH? Any data on that?
Well, I presented some of the doses that people have used. I personally have not used them, and I probably wouldn't. I think there are better drugs. The data on it is not great.
Okay. Okay.
50 to 100 milligrams for sumatriptan, just like migraine dosing.
All right.
That's what's been
Pam, is there any benefit to waiting after the blood is drawn until the time of injection when you're doing a blood patch? Let's say the blood is starting to clot in the syringe, but it's still injectable. Is that blood got more clot strength than if you put it in straight away?
Nobody's really looked at that. I think that, you just run, if you wait, you just run the risk of not being able to get it out of the syringe. So I think, and you're probably just as likely to clot in the epidural space, assuming it's not filled with saline or CSF. So.
Okay. Question for Pam and Pedram. There's a lot of questions here on blood patches and catheters. If you've used an intrathecal catheter, say the patient delivers, what do you do about the catheter? Do you leave it in? Does any local inflammation occur, or do you take it out, or do you do something else?
We typically leave it for 24 hours after delivery and then pull it because there's some data, it's not great, but some data that may help. That's our practice.
We actually take it out right away, just from, maybe it's because we're a little more anxious about our peripartum flora, but we're a little anxious about either it getting infected or something bad being put into it. But there was a study that showed that actually with catheters that were left for 24 hours, but they had continuous infusion of saline through them, that there was a decreased risk, but then that wasn't able to be repeated, so.
Okay.
I think I might chime in on that as well, in that, I think just referring to the IAD study, that there's been a lot of skepticism in our community about the results of that. In fact, they were so dramatic that many people question whether they could ever be reproduced. And many people feel that whatever benefit that might be there, if there is one at all, it's not worth the concern about inadvertent injections or other infectious risk.
So there's a few people asking here about what you should wear when you're doing a blood patch, if it's either you who's doing it or you putting the blood. There's questions about whether you should wear a gown, gloves, mask, hat. What do you guys normally wear if you're doing the procedure and if you're putting the blood?
Well, I think it's very important to wear jewelry. No, I'm just kidding.
Big watches.
Yeah. No, I mean, you use the same sterile precautions that you do for the epidural. You might have noticed in my slide that I had a picture of someone doing a blood patch, and the person, the proceduralist who was drawing the blood, didn't have a cap on. So I think both people should use the same thing that you use for epidural.
Well, I think maybe the reason the question was there is that they were gowned.
Uh-huh.
I suspect that practice is not widely dispersed.
Yeah, no, we don't typically gown. And in fact, there's been discussion about whether you need to wear a mask for epidurals, but then there were a couple of case reports that where 2 cases of meningitis were tracked back to a practitioner who didn't wear a mask, and they were actually able to track the bug and the meningitis back to his nasal oral flora, so, yeah.
I will say, if nothing else, though, Pam, even though that's not our practice to gown, it did make me think a little bit about our sterile technique. It can tend to get a little sloppy on an epidural blood patch, I think, and it certainly reminded me of that slide.
Yeah, that's true. I mean, we'll do it in a patient's room, for instance, and when you think about, somebody's kind of yucky bed that they've just been eating a muffin in, and there are muffin crumbs and so on, I mean, I think you do need to clean up.
Okay, quick question for John. When is the best time to do an inversion? I'm guessing it's not,
Oh, yes, I think
1 o'clock in the afternoon. I'm wondering whether the guy's asking about gestational age.
Well, actually, that is a good point in that, there's a lot of, people do push back a little bit on, it's not this group. This is a very engaged group of obstetric anesthetic providers that we embrace this practice, but the great majority of anesthetic care provided in labor and delivery around the United States is provided by generalists, and most of them are not as enthusiastic as us about this. I usually try to tell them that this is one of the few things actually that does happen electively and during working hours. So addressing that question, the after lunch question. But as far as timing, it's a balance between trying to do a procedure and not have high risk for reversion spontaneously, but also have adequate lung maturity in the setting of doing a procedure where there is a 1 in 200 chance of needing an emergent cesarean delivery that day. There is that same group I showed you that did the breech vaginal trial did a timing trial on this, 37 weeks versus 34 to 36 weeks. and didn't show a substantial advantage. Yes, you could turn a few more patients in the early group, but it didn't really pan out to reduce cesarean delivery rate, and interestingly, it wasn't that substantial an uptick in neonatal pulmonary morbidity.
Okay.
Actually, can I ask a question? I have a question for you. So what is the practice, both of you, what is the practice of your obstetrical groups? So say, I think most obstetricians, every place I've practiced, will now, the optimal time is 37 weeks, because I think at 34 weeks, there was also there's a higher risk of returning breech. But say they do have a successful version at 37 weeks, will they then send the patient to induction, or do they send them home and wait now that we know that 39 weeks is preferable?
Yeah, it's a good question, and it also brings up some concept that's also built in here, and something I'm going to address in a talk tomorrow, the concept of unstable lie. I mean, unstable lie, I don't think many people fool around with. They take it right into an induction, and but for the most part, we send our patients home and wait for
Labor?
Yeah.
We
Pedram?
send them home as well.
Okay. Question for Pedram. What do you do if you have someone with a wet tap who's HIV positive? Would you consider them for a blood patch? If you do, anything you do differently?
I would probably not offer them a blood patch. I would try other techniques.
Okay. And on that point, if someone refuses a blood patch or if someone's got a contraindication, you talked about drugs, both you and Pam. Any preferences for your first, second line choices of meds that you might use?
Well, I already told you that I show up with a latte, but now I'm going to do the brewed Starbucks. Thank you, Pedram. And, I do explain to them that, anything that we might give them other than a blood patch, I don't even mention fibrin glue, is really just going to make them feel better until it heals itself. So, I would try other analgesics and I do a lot of these blocks in my pain practice, so I would definitely, do certainly an occipital nerve block that's easy.
I would say if someone's high risk for any reason where I don't feel comfortable doing it without fluoro, I would refer them to the pain clinic.
Yeah, if you have a pain clinic, you can always refer to the pain clinic. But honest to God, the occipital nerve block is a field block, is a see one, do one, teach one kind of thing. So if you want to come up and talk about it.
Okay. Does anyone have any experience using dye to confirm the epidural space if you're doing or about to do a blood patch, or if you're planning to use fibrin glue, has anyone used fibrin glue?
Yeah, I have used fibrin glue. It's terrifying. I've only used it with fluoroscopy, and I would never, ever use it without fluoroscopy. I've only used it in pain patients with Ehlers-Danlos or POTS who have failed multiple blood patches.
Okay. Question for John. If you're using a low-dose spinal, I guess as part of a CSE for aversion, do you require the patient to be MPO? If you do, for how long?
We manage it like most, elective cesarean delivery. So whatever your practice is probably reasonable. But again, it's a topic I'm going to be talking about tomorrow, and I don't want to steal any thunder.
Okay, very nice.
It's my own thunder, so
I don't want to
Yeah.
steal your own thunder.
Question for Pam. How do you feel about these dural puncture techniques, epidural techniques? Do you think there's any difference in the incidence or risk of wet tap from headache from wet tap compared to epidural or CSE?
Well, that's a really good question, and my thoughts on that have changed based on the prospective study that I've just completed and haven't published. But when people started first talking about those things, I was a little hesitant because I was really thinking about this risk of, long-term headache and back pain, and I really didn't know whether that might apply to smaller gauge needles. So in the study that we just did, we actually were powered to look at smaller gauge needles, and there was no increase in that group, thankfully. So now actually I feel a little bit better about doing them, and I do like doing them to confirm midline and in someone, who's difficult in any way. I'm not really sure that I feel like it's kind of the best. I'm not really sure that I believe it's kind of like a merger between CSE and epidural. But I really do like the confirmation of midline, so.
Okay. Question for Pedram. If you're leaving an intrathecal catheter in, how long do you leave it in for after delivery?
24 hours, and then we pull it.
Okay.
Let me repeat.
Okay.
Why?
There's some evidence that the headache rate is less if you leave the catheter
But
in,
why 24 per se?
because in one of the studies, that's what they did.
Okay.
Seems reasonable.
Well, they're going to go home soon anyway. So.
All right. After you give a blood patch, Pam, do you restart DVT prophylaxis if you're using it at your institution?
Yeah, actually, I have them hold, if they're using heparin, low dose or regular dose, I'll have them hold it for at least 6 hours before, then I'll allow them to restart an hour after.
Okay. We can keep going for a bit, can't we? Question for John. This is, I guess, a systems issue. Have you ever worked with your hospital ER department or neurology department to change the types of spinal needles that are available in your hospital? If you have, how did you do it?
My God, there's so many issues to address as you move to a new system. I haven't gotten to that one yet, interestingly, and I won't be surprised, but I think many of you recognize that your peers in neurology use 22-gauge cutting needles, it's all what they have trained on, and they perceive their flow rates in terms of collecting a large amount of CSF is deemed to be unchangeable, and I'm just shocked we don't see more postdural puncture headache in this population. It's already a little bit more complex than our young, healthy obstetric population. Ask me that one in a year. I'll probably have addressed it.
I've actually talked to our neurologists a lot about it because I was kind of their go-to person to send all their wet taps. And I'm like, why are you guys having all these headaches? You're using such a big needle. And what they tell me is that, not so much their comfort, they wouldn't actually admit that they weren't comfortable using other needles, but that the opening pressure was, normed on that needle. So, but interestingly, there have been studies by neurologists using other needles, and it kind of doesn't make sense that the pressure differential would be different, right? It would just take time to reach that pressure. So actually, they have had normed opening pressures using smaller needles, but it's not been adopted.
Okay. Question for Pedram. If you have someone who's super anxious who needs a blood patch, would you consider something for anxiolysis? And if you would, what would you use?
Absolutely. I would use Versed.
Okay, that was an easy one.
What? Super duper anxious.
Pam, can you give us an idea about if someone has a suspected postdural puncture headache, where the wet tap, what percentage of those patients did not have a wet tap sort of detected at the time of epidural placement? Do we have an idea about what that is?
Yeah, I've actually looked at it on our data, and we have a special group in that we have all fellowship-trained obstetric anesthesiologists during the day, and then at night we have some selected colleagues who are generalists who also take call with us. And I was noticing that there was a lower rate of reported dural puncture at night, which was surprising to me. But there was actually a higher rate of headache from patients who were done at night in our satisfaction survey. So I suspect that they're less likely to be reported or perhaps recognized.
Okay. Pedram, do we have any idea about whether a dural puncture is associated with a subdural hematoma?
Well, certainly there are reports of creating a subdural hematoma as a result of untreated a postdural puncture headache that persists for days and days. And some patients don't know better and they continue their activities of taking care of their newborn and all those things, and I think that risk is definitely there.
To be fair, if nobody told you that this was a possibility, right, and you had a bad headache after you delivered and nobody had ever even mentioned that it might be due to your epidural, why would you even think about it, right?
I think it does get to the, you had described in your talk, what is your threshold to image somebody? And as you've done a blood patch, if you get great results, that's wonderful. But if you start to get into a subset of patients that have either had a recurrent headache or no relief from a headache or any other, obviously, neurologic findings, low threshold to image these patients. And the prevalence of abnormal findings in them is a little bit surprising.
Yeah. Well, I told you I had that one case report of the spinal catheter patient who was a pain patient who, my own patient, showed up and had a subdural hematoma. I didn't place the catheter, just let it be said. But I was interested that you said that 5% of patients won't have classical symptoms. That may be true, but anyone who tells me that their headache gets worse than when they lie down gets imaged, because that's a risk factor for hematoma. And, it may be 5% aren't right, but I'd hate to miss that,
That study is actually people who've had MRIs, and
Yeah.
they have clear dural puncture headaches.
Yeah.
But for some reason, they have that abnormal presentation.
Well, I don't doubt that. It's just that I'd hate to miss something that would be more dangerous. I would still image them.
Okay. Question for John. Help me. I
Okay.
have OBs who will not allow us to use neuraxial anesthesia or analgesia for an ECV. They think it's safer that the endpoint is that the patient has pain. So I can't read this very well, but any thoughts about how to change this sort of psychology?
Give them my email address and phone number. Happy to talk to them. Obviously, this is all of what we were thinking about 20 years ago, and we carefully moved in and conducted a lot of investigations that have reassured us in many respects of this. But I understand this is still, it strikes you as a little bit of a risky behavior to do an external cephalic version. But when you step back and look broadly at all the data and outcomes, it's probably an endeavor to participate in.
Okay. I've got time for a couple more, and then that's it. Let's say, question for Pam and Pedram. So let's say you're doing an epidural for someone in labor. Patient gets wet tapped, definite wet tap. You pull the needle out and then you recite, do a normal epidural, works great. So at the end of the delivery, you're obviously worried that she'll have a postdural puncture headache. Would you consider injecting blood through that catheter? Or would you take that catheter out and do a brand new epidural and do a de novo blood patch then and there before the headache even develops?
The data on prophylactic blood patch is just not there. I don't think I would do it.
Well, it's true that a prophylactic blood patch it's much less effective than a de novo blood patch, but those aren't de novo blood patches done right then and there, right? Those are de novo blood patches done the last day, and I showed you the data showing that there's some benefit to waiting. So even though that a de novo blood patch is much, much superior to a prophylactic blood patch, if it was a situation where it's very, very difficult or I thought the patient was going to refuse, I actually wouldn't hesitate to put some blood in the catheter if I was assured it was clean, because I would know that I would have some reduced incidence of headache, but it's not very large. It goes from about 80 to 50% in one study, right? So most of the time we take them out just for safety reasons. But if it were a situation where I thought I wasn't going to get another chance, or it might be dangerous, or I'd never get it in again, then I would probably put some blood in, because it's not going to hurt and it might help.
To add to that, I think one of the curious things about the prophylactic epidural blood patch study, it took a couple years. We randomized women to prophylactic blood patch or waiting. I was surprised. The primary outcome was incidence of headache, which was identical in both groups. A secondary outcome was pain, or pain under an area over time, and that did show a reduction, essentially, in the duration with those who got a prophylactic blood patch. The interesting thing about that is to go and lecture on that for the first few years after its publication. You'd poll audiences, ask them how many do prophylactic, how many don't, and the study had absolutely no influence on people's practice. Those that thought prophylactic blood patch was something they shouldn't do, said there's the reason, primary outcome's negative. Those that did do prophylactic blood patch said area under the curve is reduced. I'm going to continue to do it. I think that's never been our practice, but I think it did influence the way we interpreted some of the argument about timing of epidural blood patch. Specifically I think most of our community has interpreted the results and recommended best practice based on a little bit of the observational data on if you do a blood patch in the first 24 hours, you're going to have reduced efficacy. But it's possible to redefine that and talk about total area under the curve over a week. If your goal is to avoid a second or third blood patch, which, by the way, a certain number of patients seem to need, then yes, wait. Your total number of blood patches will be reduced. But if you reframe the goal at the pain experience for the mother, then maybe you wouldn't feel the same way about delaying that first blood patch.
All right, I think in the interest of time, we're probably going to call it a day then and there. So I'd like to thank all members of the panel. Excellent talks and excellent questions.